interview. No, I know really hard interview. So that.
I don't want to restart the thing, but might not have a choice no matter. I really need to fix this.
Got it. Speaker works.
One at least.
All right.
Yeah.
All right.
Yeah, turn it off and turn it back on.
All right. So are we starting? We're starting. Okay, somebody's raising their hand. So. We just need to do that. Hi, everyone. Sorry for the delay. I think we are getting started now. If you have any problems hearing the webinar or seeing the webinar, please put it in the chat and we'll check. It looks like we're getting a weird shadow right now, which I don't know what that is, but we're going to keep going for now. The mic there? I mean, this one doesn't work. Yesterday, I don't know, because where did Matt go? Because he was changed the sound, do we have to change it back? You want me to try the handheld mic? Okay, that's not what we were doing yesterday.
My mic.
No, it was working yesterday. Testing. All right, but can they hear online? That's the question. I'm asking. Just. All right, sorry, we're testing to make sure that people can hear online. Yes, we can hear. Okay, all right. I'm Patty Houston, and I'm a project director here in the Department of Pediatrics, and I'm happy to welcome you to the 2025 Roland B. Scott Symposium. We actually wanted to start today with a land acknowledgement. So we gathered today on land that was once home to the Anacostans, Piscataway, and Pamunkey. We honor their memory and humanity. We gather in remembrance of the people who were enslaved on these lands and who were forced to work without choice or reward. We honor their memory and humanity. As we acknowledge the history of this land, may we accept our responsibility as just and loving stewards. This is our prayer. At this time, hopefully, we would like to welcome Reverend Quincy McGee. Reverend McGee, are you here in attendance? If not, we will come back to him should he arrive. Okay, so we we'll have an invocation later, possibly further invocation. So right now, I would like to welcome Dr. Carla Davis, the chair of our Department of Pediatrics and Child Health, who will give a welcome, and then she will be followed by Dr. Rana, who is going to be bringing our special guest, Dr. John Downing, up to say a few words about Roland B. Scott. And then we have a song which will be introduced by Delicia Barnett. So I'm going to turn it over to Dr. Davis. go. So we'll see the top camera there. Hello. Good morning. How are you all doing this morning? My name is Dr. Carla Davis, and I am the chair of the Department of Pediatrics and Child Health here at Howard University. And it is my honor to be here today. I have been at the institution for 6 months and am so impressed with the work that has been done here for decades on sickle cell disease. The mission of the Department of Pediatrics is to employ training, research, and service endeavors in order to change healthcare and the quality of life for all children and their potential, especially Black and Brown children, and the diseases that impact them. So the Roland B. Symposium aligns perfectly with this mission. Thank you all for coming today. It's an honor to give you a welcome. I want to congratulate the organizers of this symposium, Dr. Rana, who is the director of this symposium that is biennial. I want to congratulate him. I also want to congratulate Dr. James Taylor, who's the director of the Center for Sickle Cell Disease. And most importantly, it was Patty Houston, who you've seen and has organized this entire event, tirelessly working to make sure that this information is received by you. I want to also thank all of the sickle cell warriors. I love that that name, sickle cell warriors, who are advocating, living day in and day out with this disease, and have come here in order to share their experiences. And I hope that we can all glean from not only each other's experience, but the knowledge and the experts that are here. The topic of men's health and sexual health, relationships, parenting are so important. And I'm so glad that even sensitive topics are being discussed today. I know we didn't have an invocation, so I'm wondering, Patty there, could I venture to say a prayer? All right, let's pray. Dear Lord, we thank you for bringing us to this place and this space today in order to learn from each other, in order to receive blessings from you as we gather together and are able to see what you have in store for all of us who are your children and who are blessed by you. I pray for each and every person who is online, each and every person who's in this auditorium, and each and every person who's on their way, and all that are even in the hallway, Lord. I pray that as the Roland B. Symposium for Sickle Cell Disease goes forward, Lord, that you would open our ears, you would open our hearts, you would open our minds to learn what you'd have us to learn. I pray that we would be edified or helped in our mental and physical health as we spend this time with each other. And I pray that everything that's said and done here today would improve the lives of people with sickle cell disease forevermore. It's in your son Jesus' name I pray. Amen. Thank you for allowing me the opportunity to pray for you and give an invitation. Sickle cell disease impact 100,000 people in the United States, and 1 in 365 newborns are born with sickle cell disease. 1 in 13 babies are born with a copy of the gene that can be transferred to the next generations. And we know that health disparities, which abound in our community, abound also with children and adults with sickle cell disease. As I was a training physician many years ago, I won't say how many, I witnessed the bias that my colleagues had against
sickle cell patients that would come into the emergency room with symptoms and complications. And there is still much work to be done. Advances have been made where we now have drugs. When I was training, there were no drugs to treat sickle cells. It was symptomatic treatment only. And so seeing the development of hydroxyurea, seeing the development of bone marrow transplant, as well as gene therapy has been transformative. And so we're here not only to raise awareness for the sickle cell disease, but also to honor Roland B. Scott. I was gonna say a lot of things about Dr. Roland B. Scott, who was a pioneer in this disease, a groundbreaking physician scientist, and someone who now all physicians could look up to as someone who changed the global landscape of sickle cell disease. But I hear that my predecessor, Dr. John Dowling, is going to say a few words about him. And I'm sure he knows more about him than I do. I'm just going to say a few things, Dr. Downing, and hopefully we won't overlap too much. Dr. Scott, Dr. Roland B. Scott, was born April 18th, 1909, and passed away December 10th, 2002. He went to Howard University in chemistry, as undergrad, then came to medical school, and graduated in 1934. He was responsible for the seminal paper in 1948 that described the sickling of the red blood cells in newborn babies. And it's because of that work that now we have newborn screening. When I was in training, because every baby got newborn screening, every physician, every pediatrician in the entire United States has sickle cell on their brain. And that, I would say, goes back to Roland Scott, an incredible person and very kind. I'm going to just say that he is a role model, and I'm so glad that 50 plus years later, because of his work, we are able to sit here and raise awareness and help each other through this disease. I have to apologize, I have to leave briefly, but I'm going to come back. I hope, however, that you listen, you learn, you can hear from one another, and that everything that's said here today will improve your life and so forth. So thank you so much for allowing me to give this welcome. And these next 3 hours, enjoy. We're going to have a great time. Thank you so much.
I neglected to make one practical announcement. I think the easiest to access restrooms are actually going to be one floor up on the main level. If you just take the elevator back up, there's a restroom on each side of that elevator. There is an additional one they said we can use that's kind of to the back diagonal that way, but it might be easier for you to find the one that's just right above here. Thank you.
Make it louder.
No.
Good morning. Can you hear me back there? Assalamu alaikum. Shalom. Namaste. I say all those things because we have many people I know from Pakistan, from Nigeria, from Cameroon, from Uganda, who are registered and who are watching us. So welcome to all of them and to welcome to all of you. I feel so blessed. I see. Oh, okay. Thank you. Thank you, Patty. And I want to thank, I feel so proud. I have a wonderful team, Patty, Joanne, Sahir, Ashley, and Cynthia, who couldn't be here today because she recently had surgery. But I'm so proud of those. Ashley, Tammy, God bless you. who helped put all this together. And I feel also so blessed, not just by the prayers of Dr. Davis, but Dr. Davis has been just totally awesome. There is only one other person as a human being who earned my respect over long, long time and still holds a very high place in my heart. And he's a towering personality, and that's Dr. John Downing. And John was my chair long time ago. John retired, but he continues to do wonderful work. Not too long ago, he was writing health columns in Atlanta, and he continues to do work distributing Bibles and spreading the word of God all around his neighborhood and in his city. So John, please come. John worked with Dr. Roland B. Scott directly for quite some time, right? And John can give us some of the glimpses of his work with, and you did research with him, right? Yeah. So I want you all to welcome Dr. John Downing to the stage. What a wonderful human being. Have to.
The camera.
Good morning. It's a privilege to be back here again at Howard to welcome people to the Roland B. Scott lectureship. Dr. Scott was my chairman when I came to Washington, D.C. to do pediatric residency at Howard. As a Maharian, Howard was kind of on the side for us because we were in competition. However, when I came to Washington, D.C., I came to do an internship, which was then at St. Elizabeth's Hospital in Washington, D.C., big psychiatric hospital with a big general hospital on its grounds. And we did pediatrics at the DC General Hospital. It was at that time that I found out that Dr. Scott was trying to get residents from Howard to do pediatrics at DC General, but there was difficulty. But Dr. Scott was a fighter. He never gave up. And so when I finished my internship at DC General Hospital under Georgetown, at that time, I had the pediatric service. Dr. Scott contacted me regarding my residency. And as you have probably heard, Dr. Scott can be very persuasive. And so he got me here as a resident. And Dr. Scott was known to be very persistent. And as I began my residency, Dr. Scott prevailed to get Howard to take over pediatrics at the DC General Hospital. That's the kind of persistent person he was. And so my respect for Dr. Scott goes back a long ways. I completed my residency under Dr. Scott, and he called me back after I had completed my fellowship in the University of Cincinnati to come back here as a pediatric cardiologist. And again, Dr. Scott was very persuasive. So as we think about it, Dr. Scott covered many, many different areas, both as a pediatrician who particularly specialized in sickle cell disease, but who was very persistent in various aspects of the pediatric services in the Washington, D.C. area and abroad. And so I was privileged then to do my pediatric residency under Dr. Scott. And so as this session goes on over the years, I have a great respect for Dr. Scott because he was not only persuasive in my life in terms of my career, but it's an honor to be able to say something about him at this session. Thank you.
Good morning, everyone. My name is Lady Delicia Barnett. I'm from the Prince George's County chapter of the Top Ladies of Distinction. I am honored to be here today. The Top Ladies of Distinction, Prince George's County chapter, does a lot of advocacy work for sickle cell with regards to donations to Children's Hospital Prince Woodmore, as well as the Howard University Sickle Cell Center for Disease. But we also do advocacy work and other items as well with regards to sickle cell. This morning, I would like to introduce to you Miss Harmony Smith, who is going to bless us with a beautiful song to encourage our warriors. Miss Harmony.
Let me just see if it. Yeah, I know. I guess I hope they can hear it online. But they should be able to. All right. Ready? Yep, absolutely. All right. Stop. Hey, oh, yeah, yeah. Yeah. Can y'all hear me all right out there? I'm taking my freedom, putting it off the shelf, putting it on a chain, wearing it round my neck. I'm taking my freedom, putting it in my car. Wherever I choose to go, it will take me far. I'm living my life like it's golden, living my life like it's golden, living my life like it's golden, living my life, living my life like it's golden, golden, yeah. Living my life. It's all right. You can move and groove a little bit if you want. I'm taking my freedom, putting it in my strong, singing loud and strong, grooving all day long. I'm taking my freedom, putting it in my stroll. I'll be stopping y'all, letting the joyful die, living my life like it's golden, living my life like it's golden, golden, yeah. Hey, yeah, yeah, yeah. I'm holding on to my freedom, can't take it from me. I was born to do this, it comes naturally. Strumming my own freedom, playing the God in me. Represent his glory, hope he's proud of me. Yeah, yeah, yeah. I'm living my life like it's golden. And we're gonna do a little remix for the old heads. Make my funk to P-funk. I wants to get funked up. Ha. Make my funk to P-funk. I wants to get funked up. Say the funk, I want some P-funk. I wants to get funked up. Make my funk to P-funk. I wants to get funked up.
living my life like it's golden, like you matter, like you're special, like you're beautiful. Don't you know he loves you? Yeah. I'm living my life like it's golden, like I matter, like you're special, and he loves you, yeah. Make sure you live your life like it's golden. Live your life like it's golden. Oh, yeah, yeah. Yeah. Live your life. Live your life. It's the only one you got. Make sure you take care of yourself. Freedom.
Hello? All right, good morning, everyone. Good morning. That was beautiful. Thank you so much for that selection. My name is Barbara Harrison. I am the Assistant Director for Community Outreach and Education for the Center for Sickle Cell Disease here at Howard University. I'm a genetic counselor by training and work here at the hospital as well. And also work with a community organization called the Sickle Cell Association of the National Capital Area. So from all those organizations, I've bid you welcome to Howard University. I have the pleasure of introducing our keynote speaker, Mr. Otmar O.D. Donald. So Otmar has a passion for empowerment and systemic change. He is a nationally certified healthcare navigator through the Sickle Cell Medical Advocacy Organization and a certified life coach and activities consultant in geriatric care. Committed to giving a voice to the underserved and mistreated, he focuses on advocacy in both geriatric care and the sickle cell community. He founded On the Air Sickle in 2022 as both a podcast and a nonprofit organization, where his mission is to air the good, bad, and ugly in the name of awareness and advocacy. In 2025, he was appointed as an advisor to the newly launched Inova Hospital Sickle Cell Patient and Family Advisory Council. Beyond his professional work, Otmar is a devoted husband to Chardonnay Donald, who serves as president of the On the Air Sickle Board of Directors. He is also a proud father of 2 children, and his dedication to advocacy, storytelling, and systemic change continues to impact communities worldwide. So we are truly honored to have Otmar join us today for our keynote address. Hear me? Oh, I'm sorry.
That's okay. Got it. You good?
Yes, yes.
Let me make sure
Doesn't
this is
matter,
right.
doesn't
Okay.
matter the mic.
Is it showing his,
Showing.
is it should
Yeah,
show him too though.
Yeah.
Going on the Zoom. Okay. I hope we set the right height.
Testing, testing. Can everybody hear me? We're okay? All right, how's everybody doing? Oh, that was whack. How's everybody doing? All right, there we go, there we go. All right, first of all, I want to say thank you so much for allowing me this opportunity to speak. This is definitely this is a special moment for me for several reasons, and you'll hear that in this speech that I'm going to present to you all. I want to give a special shout out to my family. They're wearing on-air sickled hoodies. My mother is in the audience, my mama-in-law, my sister-in-law, my brother, and of course, my wife. Just thank you. Yes, please clap it up, clap it up. The support. Just gonna reorganize so I can see my notes here. All right. I want to say thank you all again. Thank you for this moment, not just to speak, but more importantly, to be heard. In this room, among patients, physicians, social workers, caregivers, and parents, we don't just share information, we share truth. And often that truth is heavy. It doesn't always scream for attention. Sometimes it whispers in our quiet moments, settles in our muscles, and makes a home in our bodies in silence. Chronic illness affects over 133 million Americans, but studies show that men are less likely to report emotional distress, less likely to seek help, and more likely to die prematurely from preventable conditions. For Black men, for Black men in particular, the weight is multiplied by history, by culture, by stigma, and by silence. And yet so many of us suffer silently, not because we want to, but because we've been conditioned to. We've been told that vulnerability is a threat to our masculinity, that to survive, we must suppress. So when we talk about the weight we carry, we're not just talking about symptoms, we're talking about survival. We're talking about the silent heaviness that lives inside our bones, our thoughts, our schedules, our relationships. We're talking about the pressure to show up when our bodies want to lie down, the pressure to lead when we haven't even had space to heal. Imagine for a moment a man who's lived most of his life behind hospital walls, not because he works there, but because his pain keeps sending him back. Now, imagine that same man stepping onto a stage, not to receive treatment, but to receive applause. Applause not for what he's done, but for the fact that he's still standing, still here, still choosing life. Imagine a young boy told he wouldn't live past 18, who grew up to build an organization that now educates, advocates, and fights for others living with the same disease. He didn't just beat the odds, he became the reason others believe they can too. That's not just survival, that's transformation. These aren't hypotheticals. These are men among us. Men with sickle cell who carry the same weight we do, but turned it into legacy. These are warriors who redefined what survival looks like. These are brothers who didn't stop at breath, but they pushed toward purpose. One became a musician, using his lyrics to express the pain doctors couldn't see. One became a father who never let his children see his hospital bed, only his arms outstretched when he came home. One became a community leader, holding forums, fundraisers, and giving voice to the voiceless. And one is standing before you today. The title of this keynote is The Weight We Carry. And when I say we, I mean every individual living with sickle cell disease. But I also mean every man. I also mean every caregiver, every advocate carrying the weight of not only their role, but the disease itself. It's not just the pain in our joints, it's the fatigue in our limbs. It's the pressure in our hearts, the burdens on our minds, the silence we've been trained to survive in. We carry the weight of expectation to be strong, to be steady, to show up no matter what. Even when fatigue steals our breath and pain becomes the silence in the room, we're still expected to stand tall, and many of us do, but it comes at a cost. A 2020 study from the American Psychological Association reported that men often associate seeking help with weakness, especially when living with a chronic illness. This internalized pressure leads to higher rates of depression and anxiety, undiagnosed and untreated. This isn't just a mental health statistic, it's the emotional mirror many of us avoid. We don't talk about it, but it shows up in our relationships, in our fatigue, in how we disappear without explanation. And here's the thing, that silence becomes a second sickness, because we're not just battling what's happening on the inside of our bodies, we're also battling what we've been taught about manhood, vulnerability, and emotional expression. We've been told to tough it out, man up, push through. But how do you push through when the pain isn't just physical, it's emotional, it's mental, it's generational? We carry the weight of invisibility. On the outside, we might look fine, but inside, we're fighting battles most will never see. And society at times expects us to keep it that way, to suffer quietly, to not disrupt the comfort of others. We carry the weight of fear, not just of pain or crisis, but of being seen as weak. Fear of losing jobs, losing respect, losing opportunities, losing relationships, simply because we've admitted we're struggling. That fear is real, and it keeps many of us silent. And then there's the weight we carry that isn't always medical, the mental, emotional, invisible weight. The thoughts that creep in at 3 a.m., the questions we don't speak out loud. Will this ever get better? Does anyone even see me? Will I make it through this one? There are moments where I personally have questioned if I could keep going. Times I didn't trust myself to hold the weight one more day. Moments when my thoughts scared me more than my pain ever could, not because I wanted to fall, but because I didn't know how I could keep standing. But I did. And because you are here today, you did also. My journey is layered, and my testimony didn't begin here at the podium. It began in that kind of silence that only hospitals know. In that kind of pain that doesn't announce itself, it settles quietly until it takes over. In 2022, I tested positive for COVID-19. And for many, that diagnosis came with anxiety, fatigue, and inconvenience. But for someone living with sickle cell, COVID was a direct threat to my life. It wasn't just a virus, it was a trigger, a magnifier, a danger that turned a chronic condition into a crisis. COVID didn't just give me a fever, it gave me fear. It didn't just cause symptoms, it created a situation where my body began to shut down. My hemoglobin started to drop rapidly, critically, quietly. And I was alone. Hospital protocols at that time meant no visitors, no family, no one at the bedside to advocate when I was too tired to fight. So I had to speak for myself. And at that time, I remember calling my wife and saying, I need help. The doctors, I told the doctors that if my hemoglobin drops to 7, I need a transfusion. I knew my body. I wasn't guessing. I wasn't panicking. I was informed. I was clear. I was calm, but I was dismissed. 6.8, please, I need a transfusion. No, they said, we're gonna wait until it hits 6.5, 6.3. Is there a plan? We're checking to see if there's an order in place. 5.7. Please, I just need blood. 5.5. 5.4. 5.3. And at that moment, I knew my voice didn't matter and that all I had left in me was gone. According to multiple studies, Black patients are significantly less likely to receive pain medication or emergency intervention compared to white patients with the same symptoms. This bias has been well documented in sickle cell care, where many are assumed to be exaggerating pain or drug seeking rather than surviving. This isn't speculation, it's lived experience. We walk into ERs not as people in pain, but as suspects, our credibility questioned, our cries diminished. That kind of dismissal leaves wounds that medicine can't reach. That night nearly broke me, but it also built something in me. That was the moment On the Air Sickled was born. Not of inspiration, but out of desperation, out of grief, out of being ignored. I didn't start On the Air Sickled because I had a platform. I started it because I was tired of being silent. I needed a space to speak the truth, not just mine, but ours. The good, the bad, and the ugly. The medical trauma, the faith wrestling, the family strain, the quiet resilience. I needed others to hear what wasn't being said in doctor's notes or discharge papers. Because when you nearly die from something preventable and no one hears you, it changes you. It taught me something loud and clear, that if we don't tell our own stories, they'll either be rewritten or erased. Storytelling and advocacy has been proven to increase funding, drive policy change, and shift public perception. When patients become narrators, not just case studies, change follows. This is why I speak. This is why I founded On the Air Sickle. Because we are not statistics, we are stories. And when told truthfully, our stories become weapons against indifference. I used to think that my story started with COVID, but the truth is I've been in a fight since birth. The kind of fight that doesn't come with gloves or crowds, just quiet battles in hospital rooms, in school hallways, in the corners of my mind. I had my first sickle cell crisis before I could even form sentences. around 8 or 9 months old. And from that point on, my life was shaped by what my body could and couldn't do. Pain wasn't new to me. It was normal. It was expected, and I owned it as mine. At 2 years old, I had my spleen removed. At 5, I had a stroke that came with seizures. And I'll be honest, that stroke didn't just interrupt my life, it almost ended it. My mom was told I wouldn't live to see 15. Children with sickle cell anemia are at high risk for stroke, up to 11% by age 20, if not on preventative care. Strokes are a leading cause of disability in pediatric sickle cell patients. This is why early intervention matters, why screenings, specialists, and school advocacy are not luxuries, they're lifelines. And for many of us, it's the difference between developmental and disability. From age 5 to about 14, I had to stick myself with needles. I wasn't experimenting, I was surviving. I slept with a pump every night to help manage my iron overload, not because I wanted to, but because I had to. Because my mom was working nights and she was a single parent, trying to keep us fed and clothed. Because my body couldn't fight this disease alone. Children's Hospital became a second home. I knew the hallways. I knew the nurses. I knew which machines made which noises. It wasn't a place I visited, it was a place where I grew up. There's one birthday that I'll never forget. I was getting ready for school, just a regular fall morning. My mom, usually up and pushing me to move faster, was still lying in bed with tears in her eyes. Sorry. Can't see. There was one birthday I'll never forget. I was getting for school, just a regular fall morning. My mom, usually up and pushing me to move faster, was still lying in bed with tears in her eyes. And I didn't understand at first. And then she told me that you weren't supposed to live to see this day. But God saw it different. And that stuck with me. Because on days when I didn't think I could go on, I remembered that day. I remembered that I was never supposed to be here, and yet I was. In 2013, I had my gallbladder removed. That same year, I got married. And I say that with careful clarity, because unfortunately, that marriage was not filled with all beauty. It was filled with hardship. There were moments of deep pain, not just physical, but emotional and mental. I often had to search for strength on the good days just to stay. The good in that chapter came mostly through one role I was told that I would never be able to hold, being a father. From that marriage came 2 sons, and the title, father, gave me a kind of fuel that pain could not take away. I showed up for them. I kept pushing because of them. And though that household was hard, fatherhood became the lifeline. Hospital visits didn't stop just because I had a wedding ring or a mortgage to pay. I kept fighting, working 3 jobs, providing for that family, and showing up as best I could while my body constantly reminded me of its limits. And in 2018, that marriage ended. In 2019, something changed. I met a woman who would change my life in ways I never knew I needed. This woman will become the one I call my wife, my friend, my love, my good thing. She didn't just ask about my pain, she studied it. She didn't pity me, she partnered with me. Her name is Chardonnay. And her entrance into my life didn't erase the pain, but it did shift the weight. And baby, I don't know where you are. There you are. I'm so grateful for you. You didn't save me, you saw me. And that mattered more than medicine ever could. I'm so grateful for your sacrifice and how you have kept me even when I didn't know how to keep myself. And I love you. When you live with a disease like sickle cell, you start to believe that love will always come with a cost, that no one will stay when symptoms show, that your body's betrayal will eventually scare people off. So you brace for that. You prepare for it. But Chardonnay disrupted that cycle. She learned what foods made my body crash and helped change how I ate. She encouraged me to pursue consistent, high-quality medical care instead of emergency-only responses. She didn't just want me out of the hospital, she wanted me whole. According to Johns Hopkins, lifestyle changes, including nutrition, hydration, and preventative care, can reduce the frequency and severity of sickle cell crisis. But consistent support is often the missing ingredient. But support isn't just medical, it's personal, it's relational. It's the difference between surviving and thriving. Because even the best care plan means nothing if you're doing it alone. For the first time in years, I had someone who didn't panic when I was in pain. She prepared. She asked questions. She took notes. She advocated for me. She found better doctors and helped me build a better system. And slowly, for the first time since childhood, I began to feel like my life wasn't just about surviving. And still, the weight didn't disappear. There were moments when my emotions became too much, moments I didn't have the words, moments I was so overwhelmed by pain, responsibility, past trauma, and fear that it all boiled over. There was one night, and this is not a metaphor, this is not a moment that I'm using just for storytelling, but a real night where I stood at the edge recently. Unlike in the hospital, I couldn't speak calmly. I shouted with rage and anger. I didn't just cry streams. I cried rivers of emotional pain and mental strain. And I simply couldn't hold it together, almost damaging the one who fought so hard to help me. The weight became too much. Thank you. I did not prepare for this speech to be so emotional. And even when I was ready to fall and I was spiraling out, she remained and fought with me still. And even though I thought she was fighting against me, she held me. Not with a lecture, not with scripture, not with a solution. My wife held me physically, emotionally, spiritually. She became a mirror in that moment, reminding me who I was, why I was still here, what we had already survived. She didn't hold me to fix me. She held me to anchor me. That moment didn't erase my depression, but it reminded me I wasn't alone. Nearly 30% of adults with chronic pain conditions also suffer from depression. In sickle cell patients, this number is believed to be even higher, though often underreported. We're told to be strong, but strength isn't silence, it's survival. It's waking up every day with invisible wounds and still choosing to keep going. Depression doesn't make us weak. Hiding it does. And with her help and with renewed purpose, I now have been out of the hospital for over 3 years. I now sit on the board of a patient and family advisory council as a member of a medical institution that actually hears me, sees me, and works with me, unlike the one that once refused me. I lead trainings. I speak, I mentor, I build, and I breathe. Not because everything is perfect, but because I've learned that healing isn't the absence of pain, it's the presence of support. They say if you're surviving something, you owe it to someone else. I didn't always believe that, not until survival became my daily story. I didn't start On the Air Sickled because I wanted a podcast. I started it because I was tired of yelling in silence. I needed somewhere to take the weight I was carrying, not just in my bones, but in my soul. And I needed a space where other warriors could do the same. On the Air Sickled became a microphone for stories that were being muted, a safe space to speak that had long been swallowed, a table built for patients, not just for the providers. It was never built on likes or downloads. It was about letting the world hear the good, the bad, and the ugly, because pretending we're fine never saved anybody. But truth breaks chains. Through On the Air Sickled, I've met people whose stories sound like mine, people who were told they'd never live long enough to love, to lead, to dream, and yet they're doing all of that while still managing their pain. Sickle cell disease affects more than 100,000 Americans, and globally, over 300,000 infants are born with it each year. Yet in the United States, research funding for sickle cell disease is still significantly lower than for diseases with far fewer cases. This isn't just a health crisis, it's a justice issue. Because research follows funding, and funding follows visibility. The less we're seen, the less we're served. That's why the platform matters. That's why advocacy isn't optional, it's urgent. But let me be clear, this speech This story, this moment isn't just about sickle cell. It's about the weight we carry when we're expected to perform through pain. It's about the weight we carry when our stories are dismissed or reduced to statistics. The weight we carry as men, especially Black men, to be strong, silent, and self-sufficient, even when we're breaking inside. It's also about the promise that we make when we survive, that we won't let others walk alone, that we'll reach back, speak up, show up, that we'll use our scars to build bridges, not walls. And there's more. There's a difference between weight, W-E-I-G-H-T, and weight, W-A-I-T. One crushes you, the other holds you in suspense. One bends your knees, the other tests your patience. But sometimes we carry both. The weight of responsibility and the weight for healing. The weight of silence and the weight for answers. The weight of being a man and the weight to be seen as more than just strong. We carry the weight, we endure the weight, and somehow we're still standing. To the men in this room, I see you. You may not cry in public. You may not always have the words, but the weight you carry is real. It's valid, and it's not weakness. It's evidence that you haven't quit. To the professionals, the caregivers, and our allies, thank you for lifting what you don't always understand. Thank you for choosing presence over pity, for seeing more than a chart, for fighting with us, not just for us. To the partners who stay, who sit through the silence, who learn alongside us, thank you for not leaving when it got too heavy. You are part of the healing. And to the warriors, those diagnosed, dismissed, delayed, and determined, this moment is for you. We carry pain, yes, but we also carry purpose. We carry legacy. We carry each other. There is a weight that crushes and a weight that crowns. We were never meant to carry it alone, but if we must carry it, let us carry this together. Because the truth is, when we carry truth, we also carry hope. If they only knew how much strength it takes to walk with pain and not complain. If they only knew how many times we've smiled through nausea, through worked through fatigue, laughed through grief. If they only knew what it feels like to be called dramatic when your bones feel like glass. If they only knew how many dreams we paused to manage a body in crisis. If they only knew how often we pray, not for healing, but just for understanding. If they only knew how much courage it takes to stay alive, to stay hopeful, to stay kind, then maybe they'd stop asking, why does he seem so distant? And start asking, what is he carrying? Because if they only knew, really knew, they'd never use the word weak again. Thank you. I wanted to create this slide because I wanted you all to be able to see it directly. the difference between weight versus weight. And before I leave, I want to say thank you. These are a few of the resources that I used here. Also, if you're looking for a resource, there's material that, of course, is directly rooted to sickle cell, but there's one in particular that I want to draw attention to. Shift Humanity. This is by a woman who is passionate about change. She's passionate about influence. She's passionate about impact. She's in the audience today. Her name is Grayson Sorrell, and I am proud to be her brother-in-law. I encourage everyone to get a copy of her book coming out soon. Please go to gracelynsorrell.com. It'll take you straight to her Shift Humanity page. And her slogan is navigating your inner world to generate positive impact. Thank you all again for this time, and may God bless you. Thank you. Thank you.
Henry.
Yeah, I don't know. So here's the next slides. I did share yet.
I see how it's on the phone.
The hair.
How does it look on the?
Okay.
Are you try advancing it?
Yes.
No, there it is.
Okay, bear with us a minute. We're just getting the next slides up, and then we're gonna have Dr. James Taylor is coming up, and he's gonna introduce our next speaker.
See the button?
So here,
I just want to make sure.
Is it okay again? No, I see Timmy. Yeah, now I see the groups.
Okay. Tell them to just click this right.
The bottom one.
Yeah, just click right.
Okay. Alright. Yeah.
Good morning. Thank you for coming to the Roland B. Scott Symposium. A few words about Dr. Scott. Amazing individual who was a real trailblazer in medicine and especially in sickle cell disease. You're sitting in the home of sickle cell research. Dr. Scott, 1934 graduate of Howard University College of Medicine, was the first board certified Black pediatrician in the United States. His medical school professor had been grandfathered into board certification. He and his medical school professor were the first two African-American fellows of the American Academy of Pediatrics. As far as I can tell, he was the first Black pediatric department chair in the United States. And importantly, in the 1940s, he recognized that Washington, D.C. had a disproportionate number of children affected by sickle cell disease, not surprisingly at Freedman's Hospital. He started studying this even though he was a general pediatrician. By 1970, he had made amazing observations. The first newborn screening study in all of medicine, not just sickle cell, here at Freedman's Hospital, 1948. In 1964, he described sickle cell pulmonary hypertension by right heart catheterization. That paper has 5 citations today, and the NIH has spent millions of dollars on it, and nobody cites his paper. Inappropriate. By 1970, because he was here at Howard, a young Howard graduate recognized that sickle cell was getting no research attention. He got the numbers, and he came to the expert here at Howard, and that eventually morphed into the National Sickle Cell Control Act in 1972. And by that time, Roland Scott had been doing 20 years of sickle cell research. The NIH actually, when he got his first sickle cell center grant, he had to hire a hematologist because the NIH said that sickle cell was a blood disease and that Roland Scott wasn't qualified to treat sickle cell patients because he wasn't a blood doctor. Okay, the man had 20 plus years of experience. So we're still talking about him 20 years after his death. Really amazing man, and just gives me pause, and I'm really honored to walk in his shoes today. Importantly, we're going to be talking about priapism, which is one of the complications of sickle cell and one that we don't talk about enough. I give a plug to one of the new drugs. It's a monoclonal antibody called crinzolizumab or Advakio. Preliminary data shows that it prevents priapism. So prevention is always the best way to do this. And I really want to commend our speaker and our panelists. It takes a lot of courage to get up in front of other people and talk about priapism when you've experienced it yourself. So our first speaker is going to be Jeremy Tonkin, who's from Kansas City, Missouri. He went to the University of Missouri, Kansas City in the 6-year BA MD program, and then did a residency in urology at the University of Oklahoma, and then a fellowship at the Eastern Virginia Medical School. He's been at Howard now for 4.5 years and specializes in the treatment of complex penile conditions, including Peyronie's disease, urethral strictures, and erectile dysfunction, which is the ultimate consequence of priapism. And I really have to commend Dr. Tonkin. When he first arrived at Howard, he showed up in my clinic very quickly trying to find patients to treat, but it really is commendable that a physician would go and seek out patients. So with no further ado, Dr. Tonkin is going to be talking about Pillow Talk, what's going on downstairs, and how we can improve the sex life.
Good morning. Is it? Hi. I don't know. I think it's.
No, there's another one. So, try that one.
Sorry, we're just making sure the microphone is.
Is that one working? Back around that one?
Can you guys hear me? Okay, so this one is working. All right, so good morning.
Sit down at the bottom.
Thank you, Dr. Taylor, for the introduction. Thank you, Dr. Rana, and the organizers for inviting me to speak. So I don't have any financial interest in any of the treatment options I'm going to be talking about today. We're going to be looking at a couple different topics within men's health with a focus on sickle cell patients. Obviously, we're going to be discussing some sensitive topics and sensitive body parts. The goal is to educate, not to offend, so I apologize in advance. But as a urologist, that sometimes is something that we have to have these kind of conversations with our patients. So we're going to start by talking about priapism, which is a very common condition in men who are living with sickle cell. erectile dysfunction, which, as Dr. Taylor said, is the ultimate consequence of priapism. And then a couple of words on infertility as it pertains to patients in this population. So priapism, quite simply, is a prolonged erection that is not caused by or relieved by sexual stimulation or orgasm. There are two different types. There's what we call ischemic, which is overall the most common type and is the most common type in men with sickle cell. Ischemic can also be caused by illicit drugs, certain prescription drugs, as well as certain rare types of cancer. And then there's non-ischemic, which typically comes from traumatic events, but we're going to focus mostly on the ischemic version today. And we consider this in sickle cell patients a type of crisis. It's also considered a type of compartment syndrome. And what essentially happens is when you get the erection, the blood goes into the penis, and then because of sickling or other issues, it basically clots, it stagnates, it gets thick, and it can't run back out again. So the cells within the penis that rely on that blood will use up all the available oxygen, and then will go into basically an acid producing state. And they produce lactic acid, similar to if you've ever exercised and your muscles ache. That's a buildup of lactic acid. So you'll have that same lactic acid ache within the erection. And what happens over time, particularly with repetitive or prolonged erections, is that you damage those internal cells within the penis, and they basically die, and they're replaced with scar tissue, which ultimately destroys the natural penile mechanism for how men get erections. So this is very common. About a third of adult men with sickle cell will develop priapism with a recurrence rate up to 80%. But this really is a disease that by and large starts in the pediatric population with an average age of onset of around age 11. Most of these patients will present through the emergency room. So if you take adult emergency rooms, about a quarter of patients with priapism are going to be related to sickle cell. But if you add in the pediatric visits, about 2/3 of all priapism visits are due to sickle cell. And that's mostly because in the pediatric population, those cancers, those different drugs that I talked about are not very prevalent. So the vast majority of pediatric patients who present are due to sickle cell disease. So what do we do acutely for these patients? Like with any other crisis, we do supportive care, pain control, oxygen, hydration. But in order to relieve the situation, oftentimes we have to do something to drain the blood that is trapped. And so, I don't know, I don't think the pointer works. So the blood is trapped in this purple spongy tissue here. And in real life, it does have these little, what we call sinusoids. It kind of looks like a kitchen sponge. And the tissue there is called endothelial cells. Those are basically the type of cells that line your blood vessels, and those are the type of cells that help produce the erection mechanism. So the blood is stuck in there inside those little sinusoids. So oftentimes we have to place a needle in there to drain the blood and to break up the blood with irrigation, or to place medication to help prevent the blood from coming back in. In some cases, you can require surgery, where we essentially have to create a connection between the purple spongy space and the pink or red spongy space, which is the tissue that surrounds the urethra, the tube that you pee through. And that allows an egress for the blood, so that if it continues to fill the erectile bodies, it has a way to drain out. Happened here. Okay, so as Dr. Taylor alluded to, prevention is probably the most important part when it comes to crises. And obviously all the things that the doctors who treat sickle cell do to prevent crises are important in preventing priapism. When it comes to what we call stuttering or recurrent priapism, which, as I said, can occur in up to 80% of men with sickle cell disease who have had an episode of priapism, we use several different theories or several different methods. The one I'm going to talk about is kind of the newest method, which is use of phosphodiesterase inhibitors. We sometimes will teach men how to inject phenylephrine. That's the medication I alluded to in the last slide, so that if they have an erection that's painful for, more than an hour or two, they can inject it before it gets to be problematic. We used to, but we try not to use much anymore, hormonal blockades, so blocking testosterone, or giving estrogen to try and prevent erections. But obviously this is problematic for two reasons. One is we don't like giving this to children because it affects their growth and maturation. The second is that it essentially prevents the erections that adults want to be sexually active, so that while we may prevent the priapism, we're preventing them from having a normal sex life. So phosphodiesterase inhibitors are one of the newer wrinkles and the one that is sort of out there in prime time. There are some other things that people are looking at as well. And I don't want to get too in the weeds with this. For anybody, any physicians or anybody who want to get into the pathophysiology, I would refer you to Bud or Arthur Burnett and the group at Hopkins who came up with this theory and have published extensively on it. But essentially the theory is that patients with sickle cell have a persistent low state of nitric oxide being the chemical signal that tells the penis to get erect. And so because of hemolysis and endothelial dysfunction, nitric oxide scavenging and conversion of nitric oxide precursors, there's essentially a derangement in these patients where the mechanism is not normal. It's not the way it was designed. And so paradoxically, by giving them phosphodiesterase inhibitors, which are drugs that we use to treat erectile dysfunction, this has been shown to decrease the incidence of recurrent priapism in sickle cell patients. But again, counterintuitive, right? Because you would say, why are you giving someone a drug designed to induce erections when their problem is they're getting too many erections or prolonged erections? But by reestablishing sort of the normal homeostasis of nitric oxide, this has been shown to be helpful. There have been a few clinical trials looking at placebo versus sildenafil and some other drugs, and it appears to be about a 4-fold decrease in rates of priapism, with around 2/3 of men noting that they either had less frequent priapism or priapism of shorter duration. And these medicines are obviously commercially available. They've gotten much cheaper in the few years, and so they've changed a lot about how we think about prevention. As we stated before, so the end state of recurrent priapism is erectile dysfunction. And what happens, as I said, if you have multiple or prolonged episodes of priapism, those cells, the little purple spongy cells that I showed on the picture, they basically die and they're replaced with scar tissue. And then there's nowhere for the blood to go into the penis, because instead of having a nice kitchen sponge with all those little holes in it, you have basically a solid state or near solid state. There's about a 5-fold increase in erectile dysfunction in patients with recurrent priapism, and recurrent priapism is one of the larger causes of early onset erectile dysfunction, particularly in adolescence. And the treatment for erectile dysfunction is very similar as what we're going to talk about in all patients, with the exception of oftentimes we ask the recurrent priapism patients to use a vacuum erection device, which I'm going to show you a picture of here shortly, which essentially acts as a 3-dimensional stretching mechanism, or what the plastic surgeons would call scar massage, to try and loosen up the scarring to help the other treatments work better. All right, so we'll switch over to erectile dysfunction. We'll talk a little bit about how this plays out in the sickle cell population, but also just as men in general. Overall, erectile dysfunction is something that patients tell you they have. I don't make the diagnosis, I just listen to the patients. They say, "Doc, my erection's not as good as it used to be. It's not hard enough, or I can't keep it long enough to be able to do what I want to do." And we know from studies that this is partially an age-related phenomenon. Less than 5% of men under 40 have organic erectile dysfunction. By age 50, that's somewhere between 30 to 50%, and it goes up as you age. So that's part of it, but oftentimes it's sort of like a Venn diagram. It's a combination of factors. You can have underlying vascular issues, neurologic issues. There's always some degree of psychologic role in erectile dysfunction, because as men, we don't like to have erectile dysfunction, right? Our erections are part of our self-esteem and our body image. And so having doubt during sexual intercourse creates stress hormones. Those are bad for your erections. It's this horrible cycle. So we have to address all those different issues. But one thing that I want to highlight, aside from age and recurring priapism, is that erectile dysfunction is basically considered to be on the same spectrum with cardiovascular disease. And your penis can be sort of like the proverbial canary in the coal mine. So we know that in men with cardiovascular risk factors, whether it's obesity, smoking, diabetes, hypertension, hypercholesterol, all the standard stuff, that they will tend to develop erectile dysfunction about 3 to 5 years before their first vascular event, whether that be heart attack or stroke. And then in men with cardiovascular risk factors who have erectile dysfunction versus those with risk factors that don't have erectile dysfunction, the group with erectile dysfunction is 7 times more likely to develop cardiovascular events, like I said, stroke or heart attack. So men in general, if you start having erectile dysfunction, you need to look at what are your other risk factors, because it can be telling you that there's something else going on. So there are basically 5 treatments that we have for erectile dysfunction. There's currently not a quote unquote cure. That's what many men are seeking. They don't want to take medicines or do things. There are things in the works, but we don't have that commercially available. Probably the most common thing, which most of you have probably heard of, are going to be oral therapies. Again, these are considered phosphodiesterase inhibitors, and there are 4 available. They can be taken daily or as needed, meaning in anticipation of intercourse. And they become much cheaper as of recently. They used to be pretty expensive when they came out. The first one came out in 1997, and most of the patents have started to wear off. So you can get them for usually 25, 30 cents a pill now, even outside of insurance coverage. So they're pretty cheap. The main side effects are reversible once the medication wears off, and they're going to be things like headache, upset stomach, blurry vision, stuffy nose, things like that. There is a new medication that literally just came out within the last 6 months. It goes by the trade name Eroxon, but it's glycerol trinitrate. You don't need a prescription. It's an over-the-counter gel that you just place on your penis. And really, the studies for this were the ones funded by the company that got FDA approval. So you have to take that with a grain of salt. But essentially, they said that about 60 to 70% of men saw an improvement that was comparable or slightly less than what men reported with oral therapy. There are injectable medications similar to how I showed you, where we can place the needle to withdraw the blood. We can also place the needle in the penis to put medications that cause blood flow. The most common one is prostaglandin. That's the one that probably gives you the best erection, but also can come with some burning or cramping side effects. Papaverine and phentolamine have also been used. And we can sometimes combine these into 2 or 3 drug cocktails, depending on what the patient needs. Excuse me, external devices, which I'm going to show you some pictures of, and then finally surgery. So this just shows you sort of the reverse of what I was saying before about drawing the blood out of the corporal space. This would be how to inject the medication. And essentially what we do is we bring the patient in the office, we show them how to do this, we figure out the right dosing for them, and then they use this at home in anticipation of intercourse. The problem with this, obviously, is people don't like needles. About 70% of men stop this after 2 years just because of either cost or the lack of them being interested in continuing to use needles. No, that's this needle's going in the side of the penis. These 2 areas are the corporal bodies. The 2 ones on top, those are the areas that fill with the blood. So these are the versions of external devices. On the left side, you have the vacuum erection device, which is essentially a non-medication. So it doesn't really have systemic side effects, doesn't interact with other medications. But you put your penis in the tube, you use either a hand or an electric pump to pull blood into the penis using vacuum pressure. And then you see the little ring tourniquets at the bottom that you place in order to trap the blood once you release the pressure. As I said, this can also be used in patients who've had priapism. They will put it on and pump it up several times a day to stretch out the scar tissue, because even it's going to create a 3-dimensional stretch on the penis, even in the absence of blood flow. And then for patients with what we call veno-occlusive disease or venous leak disease, where they get good blood flow into the penis, but it doesn't stay, they could use something like you see on the bottom right, which is essentially a type of tourniquet, if you will, that traps the blood in the penis. It's called a venous constriction device. Some men will use these in combination with the oral medicines or the shots or other things, particularly if they have significant venous leak. This is an example of an inflatable penile prosthesis. So this would sort of be the end state for treatment of erectile dysfunction, or for patients who needles or other things aren't palatable to them. We essentially remove that area, the spongy area we've been talking about, and place these 2 inflatable cylinders inside. Those are controlled by a pump that goes in your scrotum, the sac that holds your testicles. And then the reservoir where the water goes when you're soft is inside next to your bladder. And so the patient can simply reach down, apply pressure to the pump, their penis will become rigid, and then when they're done, there's a deflate bone. This has probably one of the best overall satisfaction rates, with greater than 90% of men and their female patients saying that this was satisfactory. The downside is it's a mechanical device, so they generally don't last forever. On average, they have about a 10-year life expectancy. I've seen some that fail after a couple of years. I've seen some guys that have had them in for 20 years. It's kind of like buying a toaster or washing machine, right? It's a machine, so you don't know exactly how long it'll last. Some things that patients like to ask about, but that we don't generally recommend. One of the most common ones is shockwave or ultrasound therapy. There are some places here in the DMV that offer this. There were some reports that came out of England, Europe and England, looking at young men with new onset erectile dysfunction and applying sound waves or shock waves, similar to what we do for kidney stones or heel spurs or things like that, with the idea that it would create trauma to the penile vessels and the body would heal them back better than they started. But it's not currently recommended in the United States by the American Urologic Association or the men's sexual health societies because we don't yet know who is the index patient. We don't know which type of machine, which type of sound wave, and what the protocols are. So currently it's recommended that we only do this on a study protocol, which there is only a handful of them in the US at this time. Platelet-rich plasma injections, they don't really recommend at all. There are a lot of studies going on for those, but those are used in treatment of other diseases like Meniere's and certain joint issues. Testosterone, so this one's very controversial, right? Because we all would assume that if I take testosterone, it's going to make my erections better, right? That would be the common assumption. But the fact is that's not really shown to be true. So even in hypogonadal men, testosterone supplementation doesn't supplant the need for other erectile dysfunction treatments. Although we do know that men who have normal testosterone do respond better to the oral therapies. So there may be a role for testosterone replacement in hypogonadal men with the idea of then giving them medication in addition for their erections. Herbal supplements, again, this is a bit controversial. There's not really data that they're harmful to you in most cases. There are some studies saying a lot of them are contaminated with Viagra and Cialis and other things. So if you are taking a nitrate or something, they may be dangerous. But the issue is there's really a lack of conclusive data as to which herb, what dose, and there's not a preponderance of data saying that they help. So if you look at ginkgo or ginseng or ashwagandha, all these other things that have been purported to be helpful, we just don't have a preponderance of evidence to say that's true. But every now and then you have a patient that finds something and they say it helps them, and the proof is in perception. So I don't tell them generally to stop taking it. And I'll just finish up with a brief word about infertility. So about 90% of men with sickle cell will have some form of sperm abnormality on semen analysis. There's several reasons why this is thought to be the case. First is that about a quarter of men have a delay in sexual maturation due to low testosterone. You would probably say, why not just give them testosterone? Well, that may help with the sexual maturation, but testosterone supplementation is known to cause infertility by downregulating the hypogonadal cycle that basically tells the testicles not to do their job because you're getting exogenous testosterone. Testicular infarction through recurrent sickling, iron overload due to transfusion. And then there's a bit of a debate about the effect of hydroxyurea on spermatogenesis. There's been a lot of work done in female infertility with hydroxyurea, but in men, again, there's some debate about how early it started, whether the effect on sperm wears off if you stop it during the reproductive period. So there's several different questions about how that works. And one of the most recent larger studies that I could find, this was a database review of sickle cell patients, over 2,000 patients. The incidence of infertility was slightly higher at 17 versus 12% in the general population. But only about 22% of men in this cohort actually saw any sort of evaluation. And after being evaluated, half of them were given advice only and didn't require treatment. Less than 10% of the 17% of the men that were identified actually had any sort of treatment, with some of them being non-sickle cell related treatments like varicocelectomy, where they had abnormal veins around the testicle, which is not attributable to sickle cell. So there may be a higher incidence in this population, but it doesn't appear, at least based on this study, that there's any increase in need for treatment. So with that, hopefully we made up some time, and I will welcome any questions. These are references if anyone wants to look up any study. Yeah. Let's see if this is different microphone is working. So you're questioning about the neurologic factors. So probably the number one we see is diabetes, diabetic neuropathy as it affects the penis. That's going to be the most common. I saw 2 patients in the last week, young men with erectile dysfunction. I sent them for an A1C and it was above double digits, right? So that's going to be most common. Other neurologic factors can be related to surgery. For example, when we take out prostates, when our colorectal colleagues take out distal colon and rectum, so pelvic surgeries can affect it. And then of course, trauma. So the population of particularly young men who've had trauma where they're paralyzed, they might get erections due to spinal reflex, but they're not getting them on demand. So they're not able to get one when they're in a situation where they want one. So diabetes, trauma, surgical, trauma, those are the most common neurologic erectile dysfunction things we see. There's probably a bunch more, but that's just probably the most common ones.
What effect will injection have on potential STI transmission? What are you asking?
None. Sexually transmitted infections come from unprotected intercourse. They don't have anything to do with us injecting you to relieve priapism or treat priapism, or anything with the men who use medication like prostaglandin to inject themselves for erections. Your erection status is not part of how you get or transmit sexually transmitted infections. You clean it off with alcohol first. It's like any injection. I'm not sure what that means. ID prevalence.
Is intercourse post-injection uncomfortable at the injection site?
Generally, not enough to stop men from having intercourse. I'm sure just like any shot, there's maybe a little pain or bruising, but it's not enough to break the deal.
May I ask a question?
Yes.
Does regular use, early use of hydroxyurea reduce the incidence of priapism?
Yes.
By how much?
Yes. So I don't know if this is still working. Hydroxyurea is shown to decrease the incidence of priapism, and the studies were similar to the studies that I said with regards to phosphodiesterase inhibitors. The studies, when they started looking at phosphodiesterase inhibitors, most of them were placebo, PDE5s, and hydroxyurea in multi-arm studies. And so the efficacy of the PDE5 inhibitors was similar to hydroxyurea at about 2/3 reduction. The issue becomes the unknown part about fertility. So if you're going to give men hydroxyurea to prevent priapism, but we don't know what it does to fertility, is it safer or better to look at PDE5 inhibitors? The problem with PDE5 inhibitors is we've only used them in a daily fashion for about 10 years. So putting a young guy on them and thinking, well, maybe you need to be on them for 30 or 40 years. We don't have 30 or 40-year data to know what happens, right? And so there's trade-offs to all this stuff.
Dora Rogers had a bunch of patients in Texas where people who had quite severe priapism, she used super high doses of hydroxyurea to really reach the toxicity limit. And she showed that you could undo a lot of damage even when they've had priapism for a while.
Right. Yeah.
Okay.
Thank you.
I think it was fine, so we're gonna, go from panel, but it's fun to say. Yeah, the panel can start making their way to the stage while we transition the AV. You said there was support. Right there. Yeah. We put 4 chairs there if you want to just sit with the panel.
Okay, that's good.
That's good.
They show them upstairs. You guys know. Oh, there you go. All right, you big ball. Yeah. All right, so. Yeah. Key this,
Let's say external display is disconnected. Why does it say that? I was gonna put that up just for a minute while they were walking up there. Online people.
Just for the online.
Yeah, just for a minute.
Okay.
Is that gonna mess you up?
No, I can stay there. This one?
Yeah, just that shows that.
For the Zoom, right?
What's that?
For the Zoom, right?
Yeah.
Okay. Yeah.
Okay.
Okay, there we go.
I mean, as soon as you're ready to switch to your camera, you can. I just wanted to show it. Oh, there we go. We can start then, right? It looks good. All right, let's see.
It's all good.
All right, so it's showing the panel.
Yeah.
I'm gonna say that's showing. All right.
I think Kendall has to move a little bit closer in. Is that possible? So,
Yeah, get a little cozy.
okay.
A little bit, just a little bit, just a little bit. Okay. Now
Hey there. Thank you, everybody, for being here today. And thank you, Dr. Tonkin. That was a wonderful talk. We're moving on and we're moving to our next section here, which is a panel. This panel will be led by Dr. Kendall Moody. He is a assistant professor here at Howard University School of Social Work. Dr. Moody will introduce the panel. Why don't you come on up and.
Yeah, it might not work so well to project, but, we good to start?
Yeah, you're good to start, and, and there's another microphone here if you wanted to.
That's.
Yeah, we could just pass it.
Well, good morning. Thank you for joining the introduction. I'm Kendall Moody, the professor up at the top of the hill in School of Social Work. I'm a researcher in sickle cell disease. I've worked with patients with sickle cell disease. But more importantly, I'll be your moderator for today. Just really quick, I know we're running low on time, but I just want to know who's in community with us today. So do we have any healthcare providers in the room working with patients with sickle cell? Please raise your hand. Healthcare providers. Even not sickle cell. This healthcare. Okay, there we go. Yes. Medical students, any medical students? Yes, awesome. Any warriors, any sickle cell warriors? Right. Any community-based organizations here? Awesome. And anyone else who cares for family members of, yes, we are in community. I think we're in store for a retreat. We had a panel discussion, which almost turned into a panel itself with all the good topics that we're going to talk about. So I'm actually going to have the panel introduce themselves individually, and then I want them to answer the question, how has sickle cell disease impacted each of you specifically. So just quickly, I'll introduce Devon Bryant, Tayshawn Bronner, and Ms. Lakita Bruzon. She's going to actually explain her positionality there in this discussion of men with sickle cell disease. So Devon, I'm going to start with you. Just introduce yourself and talk about how sickle cell disease has impacted this person.
Morning, everyone. Good on Friday. DC, one of these, and for me, sickle cell is happy. It was a busy, it was, I didn't think I was gonna be here sitting, and everyone, so it was having that, it was very not physical, but it's very. Everybody, my name is Tayshawn Bronner. I'm 33 years old. 6'7" and had to be both physically and mentally. It's just, it's a break everything. It's everything. No matter where we go, you know, we have to worry about a issue, whether it's the future, whether it's fatigue, whether it's not apathy. Can we get more into it?
Everyone, I have no feelings. And my wife, and mom, to the
Can you all hear us okay? You hear us okay?
They see online, it's coming across low.
Okay, all right. We'll
Speak up as much as possible.
we have to do some idea. Some of it is a little low up there, but we'll try to project. So, you know, as a social worker, you know, we know that we socialize boys and girls differently. Men are taught to, you know, not show emotion, to, you know, showing emotion can be looked at as weak. We tend to socialize our girls to show emotions, be a little bit more nurturing. So I'm very curious, and we see this in the research too, where girls with sickle cell, women with sickle cell report having pain crises more often than men. So I'm curious, I want to hear from the three of you. I'll start with you, Tayshawn, on this. How has this shown up in your life? Have you noticed that you know, have to sort of suffer in silence because we looked at as people?
So what do you, I'm actually on a teacher, you know, I live in sickle cell. You know, quite understand what I'm going through. I mean, when I was younger, my mom said to me, I was like, I used to hospitalize a lot, and I used to have to go back to school. You just say, oh, whatever you do, my mom used to try to give me packets and stuff, trying to go home, but it was always the same, you know, especially when it's the same ways to involved for a certain period of time, but then sometimes the last few times, it's like yellow. People don't quite understand them while I'm acting up. People get involved with me. And even as a child, I was crazy because I used to make fun of them earlier. I had just standing up, you know, this was different from everybody else. So it really feels that I can't, not only it's opportunity to do, maybe to kind of those calls for most of us.
They've not the same question.
For me, I would say, same way I was on the introvert field, but again, I was like, you know, hey, I have sickle cell about God, but you know, there it's like not information back then, so people didn't, you know, about it. So yeah, so after a while, I just like, hey, I have sickle cell myself. I said, when I get to the hospital or whatever, I mean, you know, I'm already push that through or whatever. Hey, you get it through, or down the road, just to get my shit still pretty fast. So, you know, this gonna go to that's, yeah.
So I have a specific question for you because your husband is here, and I fielded these questions beforehand, so she knows questions that are coming up. But how as a caregiver, as a spouse of someone with sickle cell, have you noticed either in your husband or your children, that they're sort of pulling back this idea of not being hurt?
Yes, I have experienced that my husband will kind of go over his in a place of wanting to take the but I think over the years he's gotten better with it. And I mean, I heard it's very expensive. Being very out but he's definitely moved with voicing.
Amar, the previous speaker, he talked a little bit about, talked a lot about the importance of having a support system and being able to rely on that support system. So this idea, I want you all to talk about this idea of feeling as though you're a burden, but then also talk about your experience with your support system having some. We'll come back here with Davon.
So growing up, my support system only consisted of my mom. She definitely would have been here, but she had to send two brothers. Yeah, so my mom definitely took a lot of the toll on her, and I didn't understand it when I was a kid, but looking back then as an adult, dang, like that was life. And I have older brother, but you got to see so it's like you got to most of the time. Like the first one, the second one, staying out the hospital, it was also called a lot of financial strain, and you know, that was but for me now, I thought I had working with George Washington, in the ground field. So she definitely helped me out. And I know that's still challenging, very still, but I said she's a keeper.
Hey, Sean, same question as far as support system. How do you rely on your support system?
All right, well, fortunately, my mom very passionate with me. My mom was like, my mom, yeah, anything going on with me, she thought that with me. So like, I'm fortunate enough to have, like, my really come with my mom from the same way. My mom had silly, everybody was so supportive of me. But there was times where I realized too that my other siblings could feel that I'm getting able to think with people. You know, I'm always in the hospital, and my mom's always in the hospital. And all my ways at home, I'm always, you know, I guess the government felt like I was doing a little bit more attention than the other. But as far as very wise, my mom, you know, silly was the only people I feel that I'm not able to. You know, I feel like anybody else, if I get sick or I get sick, my legs hurt, I get walk, they have to like literally, you know, take time out of their day to show them, hey, for that previous service, my previous service, got a little potential to say, which I could call out when they work, but and I felt the pressure. I felt like I was in the work, you know, I can't even control it. And those days where you don't think of it as sure, she's good. She's like cancer. And that's how it's okay. You know, when I call my mom's already really out of the 7 days. You know, so I'm always really, you know, but my immediate solution, I definitely felt, you know, I had to support, very important. I was very important.
Mr. Kidd, I'm gonna come to you in a second, but I want to just elaborate on this. So you both felt like you did have support, a support system around you. How did it, what was it like to have to call on that support system during those times where at your most vulnerable, when you're having pain, not able to even go to school or work? You know, what was it like to have to pick up that phone or go knock on that door and say, hey, you know, I really need some support like that? What was that like? We'll start with you.
Well, me, I unfortunately about everything affected, but it will be times where, like recently, you know, my lady was very go to the hospital. And I think my mom could really work with something, but my mom see, what if I didn't want to come in? I did feel like my mom showed that show. she wanted to show her face. She wanted to show her face, but I do try sometimes to break around out of sleep or go out of work another time or her on a lot of things that didn't have effect. Sometimes she would give birth just to improve her job. And sort of truly, and so my age is to do a first shift for her because for me, so so only that this past weekend I was in the hospital racing. So before going, my girlfriend she helped me do everything. It's the officer dressing up everything, and you know, just sitting the officer. And I don't know, like it was bad. You know, she did, you know, this whole and stuff, but it was very rough, and then just having the experience that I had recently with doctor, asking for different pain medicine or stronger pain medicine, and like, oh, we look at your brother, and you know, looks good. But I think I'm still pretty, crap. You know, but the chemical blood is pretty good. You know, we're doing a little bit. Sir, I wouldn't get here, like, if I shouldn't do it. So yeah, I was this weekend, and honestly, I didn't want to list the hospital because I still had my life in and out the hospital. So, you know, I mean, I tried to take care of it at home, not to help it. So I was sorry.
I'm gonna ask, this, you talk a little bit about, we just heard that, it could be a challenge for patients with sickle cell, especially men to have to muster up that courage to say, you know what, I really need help. So you're in a unique position where you have children and a spouse with sickle cell. Talk a little bit about your experience caring for your children who may be sick, and also your husband may be sick, either at the same time, different times, and the strain that may have on you.
Yeah, so there has been where my daughter is in the hospital here at Howard. Here, emergency. I was putting the time because I'm too new to be cared for at the same time, really want to be. So with his blessing, he told me what I thought. But I have seen him also kind of put himself hold to but then ahead of himself. And my experience the care that I have in the sport is baby whatever they need, whenever they need, I'm not right, I'm available. They're not the old. So above all, anything else, they come first. Next time.
Has there ever been a time where we know, especially with children, that if there's a fever, you know, stop what you're doing, you know, emergency room, take care of it. Has there ever been a time where your children were sick and you needed to stop what you were doing, and that played a role in either your ability to go to work, your ability to just self-efficient?
Yeah. So I was in school, also working full time, you know, $2 that exit therapy counselors, ER visits, there have been times where I had a lot of work in this class, and then unfortunately, that was even part of my life and the time was still is, but it looks a little bit different now, but while it is occurring,
Did that play a role at all? Did you feel overwhelmed? How did it impact your mental?
I would be the best to sit here and say that it was me who got through that. It was nothing but a work of strength to get that. And outside of that, I made sure that I had time to pour back into myself and I can't be the best version of myself without making sure that I'm taking care of it. My husband works a great job of making sure that I'm taking care of it. I just need to give it so much of myself.
Good. All right, so I'm gonna segue a little bit. Brothers, we're gonna talk about mental health, which is a stigma not only in the Black community, but among males. Black. So can you talk about how sickle cell disease specifically, any specific mental health challenges that you have had to overcome in relation to sickle cell. Let's start with.
Yes, I mean, there's some, obviously, a lot of time, so I never feel like I'm to see. I never, I always have fun seeing, my brain is always, it's always moving. It's over, so, not only like, from government, obviously, don't take very much, so, but I have, shown, I think, anything, the most of that. So I have felt, it's financially issue, because like everybody else, but I also have to take care of things that you probably don't even realize. So I have to modification, I have to. I'm always thinking, if I get paid by saying, but I got to pay for it tomorrow. There's something to call out to, and not call out to, then I have to worry about my job, possibly, because I can't do that at that time. Or it's just like a lot of new things that I think of every single day. I go to work with pain almost every day. Like no other people, whether it's creation or money, I have to go to work. I have to, so I have to be personally, everybody what's happening on top of all the things that we do. And it can be stressful. I have to always tend, now I have to tell you I'm okay too, So it's like, okay, it's a lot. And sickle cell, that's very asset of real body. Physically, emotionally, financially, spiritually. So, when I was in the hospital Sunday, it, but I still wasn't feeling 100% being out there that patient that I need. Again, I decided a new job. I'm still under my time to do probation, so I was telling the girl, I said, I would work tomorrow. And I got up like 11:36. She's like, you got my book. Yeah, but I'm still in my place. So, I gotta, I know I feel real, but I don't want to tell that God, I think probation. So it's like, yeah, you gotta think like that, I definitely need to get home resting, but it's tough. So, I get going out, I get right documentation, but it's just, trapping me out, so it's here, it's like double incident all the time.
So then how do you cope? It's almost like you're doing the social calculus in your head of different scenarios that play out. Don't go to work. How do you cope with the mental health, the social aspect, the financial aspect that can come from? So how do you cope with it? There's so many things going on.
So I do journal, I do more system exercise, which I think in the hospital, I do so. And like I said, it's now getting women just go outside, walk, polish until it's not. And yeah, just things like that. I like comedy shows, so I got comedy shows. I get sauce at least twice a month. Those are the stuff things that I do. So it. I'm being hoping it's tough, right? I've been on myself, I'm saying I got the purpose which you hold. It's tough. I find that I always keep myself busy, so or to keep myself moving forward. Really smoke time. Reduce smoke time. I'm just trying to help myself forward. I'm meditating. I work out a little bit, I don't do things because I want to be so sick, I was sick. I fight but then other things I fight, keep my mind off certain things. I think especially It's tough. It's, try to keep my mind off, but, work a lot, work high school,
I won't put you on the spot, and ask you. What is,
I
won't do that, not do it, but. What keep people in mind is just sharing. From a caregiver aspect, two young children, spouse, what is it that how does mental health play a role? And what are some things that either your children or your husband do to get through those times where it feels a little bit more challenging?
One of the things that I do is making sure that I'm protecting myself, because I'm not that's running for myself like free. So for me, I'm introverted, so that's time away from all the business that I'm supposed to be doing. And whether that's just doing something by myself or going out with a friend, that's what I tend to do with that.
Okay.
And they prioritize it.
And it works.
Yeah, it works.
It works. Once you get through those tough times. All right. I'm gonna switch gears again. We're gonna talk about dating. Dating. So, I'll start with you since you have the mic with him. When you first met your husband, how much did you know about sickle cell disease? When did he disclose that to you? And what was that like?
So it actually came up in conversation with his mom. And he wasn't going to bring it up, she was. So she mentioned that he was with her, and they were unaware that I had the treat.
Oh.
Yeah, they were unaware that I had the treat, so we kind of got into discussion with there, but also I had a husband who's on sickle cell, so I was already knowledgeable about it. I was already knowledgeable about it.
Y'all hear?
So I was already knowledgeable about sickle cell, because I had it. We weren't in the same age bracket, but I was knowledgeable with it. It was not the day in, day out stuff. So I think it came up.
And when found out, did it change your perspective on like family planning? Did it go into planning?
It came back up again when we found out that we're expecting our daughter, so that's not really.
Okay. So my guys here, say it again.
The other one,
The other one might be, okay. Okay.
Something like that.
Yeah.
Really close to,
Can y'all hear me on this?
So, I think I'm gonna use this, Dr. Ron.
I think I'll use this one. That sounds like we're gonna use. All right, the guys here, what has dating been like? And we just heard about practice. What has dating been like for the two of you as far as disclosure, as far as, again, you heard about privatism, that type of talk when it comes up. What's it been like for the two of you? So before me and my girlfriend was started dating, I sort of fought with it. I used to be ashamed for disclosing that I had 6 years old. I didn't know the wrong with everybody. I think I did. So I told her, like, hey, I see this or didn't know about it. She said she never really heard of it, but she started with her own research and stuff. It was, again, really inspired me. And but yeah, so it's don't worry about it.
So it worked when you told it. At least they know about it over a year. Okay.
Me personally, I usually don't feel that stuff. I don't even feel like last conflict or something. It's weird I didn't have a response for it. I feel like sometimes I say we don't go somewhere where it's school, like food, like certain things. Some things I can't do. Some I always feel like that's a burden on the too. So I try not to. I don't mind. If it pops up and it comes up, just the only person I always feel like to be way I just feel like it's issue that is the problem. And I know there's a problem with it. And practice is point. I don't know who's doing it. Grade school, I used to practice, not knowing what exactly practice was. So let's say that two parties to the floor, or two parties to the board, to do something whatever. And never have the right, people, you don't know what's going on. You're a child, you don't know nobody else is doing that. Something is, like, you doing something else, you know what I'm saying? So, like, I used to always be embarrassed to like stand up in certain situations. Mind you, I didn't know what was going on. I didn't know why I was doing that. It wasn't nothing that I saw, it just happened. And those know the official language too. And I know we're talking about dating and he did so when I became an adult, I had a really, really bad practice my story. And again, I didn't even know it. So I slept through it. And when I slept, I'm really saying, like, got a time frame to release baptism or to permanent damage. So I slept through it, I know what was going on. And the next morning, it was still there. And I went to emergency room, and they tried everything they possibly can do to fix the baptism. And there was nothing they could do, like, it wouldn't, like, even at that moment, they did, like, it's this operation where they look like, they put something in, try to release as much blood as they can. And that did nothing, it just stayed like where it was. And like that surgery operation also caused damage to it, because you basically trying to get blood out of something that get blood in a certain way. So anyway, that caused permanent damage to me. The timeline, I'm 4 or 5 hours out of the town. There's nothing they could do. And so I was dating somebody at that time. And when I was dating at that time, I couldn't do it, you know what I'm saying? I couldn't get it up. I was able to. So that had so many different, like, you probably say right away, but first of all, mentally, feeling yourself, it's not the same, and eventually things can work out with because which wasn't the same. And that mentally had a huge total to a point where I told myself I was not going to do something new. I was not going to try to fix it. And then I looked around all over the floor, different types of solutions, treatments that can help with that issue. And I found them. But at the moment, my insurance company can help. So I had another insurance company to help that. And I had to pay off. I just a way to feel like on the back. I couldn't put it over myself. So eventually I did get like surgical operations to fix that. And it's, like you said, it's a mechanical device, so it's not perfect. And it will never be the same. If I could pay to get it, if I could get it right now, I would, but I'm gonna be okay for now. But between my relationship, that's something now that I'm doing. I'm dealing with, the right direction, usually the right direction. It's a buildup. But when it don't build up, like, we might as well build it, I have to build it up. So it's like, you gotta kind of make your mind like, oh, if you don't have building something, you gotta try to, talk over it while you build yourself up to a point where you can feel natural. So like mentally, that's crazy too. Like I can't just, it don't naturally happen. I have to make it happen myself. So it's like, the person don't know what's going on, you know what I'm saying? It's just a lot. So mentally, that was out for me, but when it comes to relationships, like that's still hard. And I haven't been really since that happened. And that's what the stars from that. I feel like the person we because I was supposed to be, you know what I'm saying? And then I got to find ways to disclose that and not be authorizing it to do it. So relationships have not, you know what I'm saying? Like it's tough. But I'm still, like if I didn't know this way, I took the steps to go to the hospital to fix it right away, but I didn't know do it.
They got anything to add to that?
Now they're saying online, they actually hear better with either no mic or the
Dr. Ron. You may just have to project our voice.
Maybe I can. It's a little loud. Bring it closer.
Bring it really close now.
All right.
Oh, see, that's good.
All right, so I haven't personally, dealt with primary, but, when I was a child, I did hear, you know, we had a prolonged erection for, I think 3-4 hours, that we go to the emergency room. Recently, like maybe a couple of years ago, I'm just now learning the medical name for it. But like I said, thankfully, I haven't experienced it yet, but again, that's something that I know that, you know, can occur with having this disease. Yeah, so.
How much information has you've interacted with your doctors? How much information is exposed to you all about sexual health, dating, privatism, any of that information relates to you? Not to put any of your doctors in here, push that spot.
For me, I guess, cause I didn't start dating till like in my early 20s, so, I mean, yeah, just regular conversations, things like that, but nothing too outlandish and crazy.
So there were conversations that you had.
Yeah, a couple, yeah.
From my experience, not much. I mean, I don't remember, I never asked about it. And I don't know if they do say like, I never really asked about it. So, that was much conversation.
Yeah. So, you know, it's sort of, I guess we'll get to the Q&A with the audience, is that right?
Yes.
Okay, so let's tie this all together. So we know that, you know, men with sickle cell disease, it's an added sort of pressure to dating. Don't show any weakness, sort of suffer in silence. But then there's this added pressure of, well, that it enter into the dating scene and engage with the mental health system, pretty down and face stigma. So there's medical professionals in the room, there's medical students that are in the room, who may or may not have experience with sickle cell patients. What is one thing that you would share with them when they leave here that just gives them a little bit more information about their experience with sickle cell disease outside of the emergency room, outside of the inpatient unit? What's something that you would want them to keep knowing about patients with sickle cell disease? We'll actually start with
Overall, I would say that you guys play a pivotal part in getting that son, the husband, the uncle, the friend back to their family members. So the care that you provide is important. And to just show empathy and to listen. I know that sometimes you may not understand everything of what they're saying, but sometimes people just want to have a listening ear.
I would like to say sport is a major thing for having success. Like, we are the warriors. We don't want to go through the actual pain. You know, actually, we go through, but people around us make it happen. From my legs, like disabled or I go back in crisis alone, I can't do much. But the people around you, gotta have like, it's good to make sure the children, the people that go around us feel like they have that support. There's been times where I felt like I was running wrong with people and I had to pretend like it wasn't it. You know, there's times where even my boss knew that I had crisis, stuff like that, but I didn't feel comfortable enough for me to even bring that to attention. So I had to do the whole day to a point where I was in the hospital a week after that because I didn't act soon. So support is a huge thing. So we are the warriors, but try to make them like guys, keep us together.
Never judge a book by its cover because, again, you go through a lot, and even like I said, my hospital says I had to, you know, not go suit on, but you know, I had to go to a gala. Like, I'm also a nurse, you know, I shouldn't have to dress like, you know what I'm saying, like I'm Bruce Wayne or something, you know, like I'm not, you know, drug addict or anything like that. You know, I need medicine, but I'm like, I'm not a thing. Like, I'm not being, just like, hey man, I got a cheeseburger. Like, no, you know what I'm saying? So just like, give us a little bit more compassion. We shouldn't have to feel like we gotta, wear our Sundays best to go get the medical treatment.
Any questions? Any questions from the audience? Someone down there able to help out?
Oh, do it.
Okay.
Everyone. And I love what he has to say about we need to show up and be supportive and be empathetic. And as someone that's in the learning stage of that, what are things that we can do to practice that in a way that's understand what's you guys and still like keeps that like professional progress. So how do you do it? That's what sales and still engage with that. I don't know.
So you asked how can you. You asked, is that, okay, is that. You asked, how can you be professional and supportive at the same time?
Like, wait, keep in mind, like, as a student, as a still like.
I would, again, like when we spoke on here, never, like a lot of times I feel. A lot of times I feel like I'm being judged by everybody. By everybody, I feel like I said, first time going to like any pharmacy, ask them for like opioids or something. I feel like I'm being judged, but I feel like I'm not believed. You know what I'm saying? If anything, just always show compassion, always speak nicely, show empathy. Like I understand what you're going through. I understand how to reciprocate. Just try to be, I'll be professional with it, but just try to be as empathetic as possible. Let everybody know. Let them know, like, yeah, I understand what you're going through. I understand. Like, just make them feel like you actually care. Because anywhere else, like 6 or 8, like abusers or something like that. Don't make it feel like that.
Thank you.
Yeah, to add to that, I would just say, if you have like family members, even if you don't, just imagine if you had a kid, that has sickle cell, just like I wouldn't want anyone to treat my child, sibling, cousin, whoever that you really love, like near and dear, like just like, just be like, hey, how you doing? Blah, blah. Yeah, but like I said, you can still, like I said, keep it professional stuff, but like I said, it's like a fine middle line,
Just to add a little bit more to it, like, just to add a little bit more to it. I forgot what I was gonna say. I'll go back. I get it. Want to answer?
Yeah.
Okay.
Okay, so a lot of times. Thank you. So a lot of times. Hi, my name is Ice. I came to this country year 2000 because, my family was basically major in the country. So, I'm Dr. Robin. So from a word standpoint is that majority of the time you will judge, especially if a majority of us are illiterate. So especially the neighborhood that I stay at is predominantly like a lot of I see a lot of so majority of the time I feel like judged. So a lot of times the majority of us, as we're constantly in pain, we're not gonna look like we're in pain. So we could just be sitting there thinking about something, looking at something, we're not crying, and we get judged by that. Be like, or when they look at our blood test. So it's not gonna show a symptom like somebody your crisis is not gonna tell them like what our pain
like bring shit and stuff like that, and a lot of people just look at us and just be like, okay, she's just in a hospital, or he's just in a hospital for another dose or something like that. So it's not about looking at the person and looking at the results, that is just about listening to the patient and knowing how they feel to get to the point of it. Because a lot of times I go to the hospital, I try to stay where, like, I know where I have my doctors, because I'm allergic to a lot of the medicine, so it's just that a lot of questions that go over and stuff like that. So, this is like, it's just gonna be somewhere where it's like a judgment and stuff.
What a question, I think.
Hey, Mom, thank you guys for sharing the story. I'm gonna get back to you from here. Also, this is a parent of the way, it's a young kid as well. I'll put that into consideration in reference to maybe the old people, especially because they're minor. This is the most of them studying as me. And then for you guys, when it comes to your parent, and you're the person what traits and characteristics do they have to help you feel supported in your journey? And then mom, what traits and characteristics do you have to I have these kids too, so I'm still trying to learn and understand and, be the best that I can. I understand, I'm sorry if I'm looking this now, I'm doing this job. But just, supporting her in the best way to just, grow up and just like, okay, I can do it, or I can't. So again, what characteristics did, what support system show you going on, and what traits did they, display to just help you guys, get through it. I was saying, I have two daughters as well that has sickle cell. So I was saying opening up a space where she can communicate to you and let you know honestly how she's feeling, instead of just kind of coming in and trying to treat it. Okay, we're gonna give you medicine, but listening to her and allowing her to tell you how she feels. Or sometimes they don't even have the words to put to what they're feeling, but her to be able to come to you and tell you, or just sit with you and be in your presence and know that she's supported, that she's heard, and we can sit here together and not say anything, but to know that there's someone in your corner that is gonna fight for you, that would be the voice if you don't have one. Knowing what suits her, and a lot of times, whether that's something small or, bringing something to her that she might enjoy, but overall, just being that listening ear can have a major impact. Yeah, and her having that space to know that she can come and tell you anything, not just from sickle cell, but that you are her best.
Well, yeah, there's an online question for Devon. How has your experience with sickle cell shaped the way you define manhood or masculinity?
So for me, I think, like I said, there's a stigma around the whole topic of masculinity and the liberal outside sickle cell. But for me, like I said, I held a lot of stuff in as a kid, but now as an adult, got to find healthy outlets, ways to express yourself. Because I ain't gonna lie, I be feeling like I want to crash out, but I know I can't crash out because I'm going to do everything I work hard. So, you just gotta, like I said, find like a support group or support pack, so to speak, and that will help you outlets.
And so there's this point in which, from the doctor's perspective, I would give more in because my patient can communicate but there's a fear that, there's gonna be, less of this person. You probably heard this, right? The doctors up there told that you do too much medicine, patients stop breathing, and then you have to, disability needs slow. So I wanted to know from your perspective, maybe either you're in pain from this problem being, and you know, the medication that's not the pain, and in the back and say, oh, you know, if you're really because it's supposed to last, they or, you know, to give you more, you might basically stop your breathing. How do you feel and how would you select a doctor to look at that? That situation, that's a good question about kind of physician. I don't really much medicine to stop the pain as possible, but then there's this side effect of being stopped doing immediately. So just share how you feel like what a doctor and what your approach that situation.
Is that for both of us or just anybody? All of us? All right, when it comes to pain management, pain medicine not necessarily the only thing that you can do. Every time I'm in the hospital, I get like heating pad, I get a heating blanket. They usually put us in like fluids and stuff like that. If I'm like, I'm in pain, like I'm in pain. And it's the other things, it's just until my next dose. But if I'm constantly bringing in the heating pad, so packs that you can squeeze, the heating blankets, make sure like fluids constantly going, because water, like, and I understand that you can't keep bringing this medication, but there's a time when you want to rest. So, I mean, just let us know that you understand this, let us know that it's a little too soon for you to get the medication, but as soon as there's time, there's a medication, it's good for medication, but we in pain, and pain is just like, kind of hurting, it's like, that is constant pulsating into my kneecap, that just won't go away, I can't go to sleep like that, you know what I'm saying? So, it's a lot of pain management, it's not necessarily just about pain medicine.
Can I say, can you give me?
Yeah.
Can you give me? Yeah. I've been taking care of children and young adults to take a 15 now, more than 40 years. And I think one thing that those living with sickle cell disease, but also those around them, the support system, and the physician and the caretaker, the receptionist. I think one thing few people realize that not being believed the person is pain is the worst kind of pain you can possibly believe. That is the worst pain. Nothing hurts more to a person who is in pain. And no two people react the same way to pain. Some would have expressions of pain, some would be trying to keep themselves calm. Some are naturally calm. They can have 10 out of 10 pain, but their face is very calm. You say, well, you don't look like you're in pain. So those kinds of things, they cause pain for the patient not being believed. So advise under all circumstances to believe the patient. Believe the patient. And negotiate, talk to them, what amount of medicine helps you. No two people handle morphine the same way. No two people will get relief of pain with the same dose. Everybody is totally unique. Yeah. When Dr. Durbar did study with pain and morphine pharmacokinetic, because some people had 4 times the level of morphine in the blood with the same dose versus others who got rid of it in a few minutes. So they needed much more. So, and I think knowing more about pain, biology of it, but what takes care of it, for patient is so important. But we are not perfect. Physicians are not perfect, and patients are not perfect, and family members are not perfect. So in that imperfect world, I think some amount of patience and some amount, I need to teach this person what saying, this guy is so cruel. He's such an idiot, this doctor, he doesn't know anything about it. I think a little bit of patience on that side, but I think a lot more is needed from healthcare professionals to understand about pain and its treatment, and it's very complicated.
Sorry, hold on. I just wanted to her question. So in regards to like the pain medicine, so again, my most recent hospital visit Sunday, they gave me 2 rounds of morphine, which really didn't really do anything. And then I asked after the second round, I said, hey, still have pain, give me something a little stronger, maybe the audit or Toradol or whatever. Because again, I know what helps me so I can get up out of here, So the nurse said, okay, we'll talk to the doctor. Doctor came in like 5 minutes. And that's when he's like, oh, your blood levels and this, that, third. But I'm like, yeah, but I'm still feeling the pain and I know what helps me, you know what I'm saying? And again, I Googled this man everything because he was just, yeah. But I'm just like, how have you been a doctor for most of my life, 25 years, but like you like coming at me like this or whatever. And the only reason that I was able to get the medicine was because a hematologist had to, like, hey man, it's a sickle cell patient, he needs this medicine, like give him what he's asking. So yeah, and as far as like the side effects, because again, the medicine does a lot of the side effects, like itchiness, constipation, drowsiness, organ damage, all these things. So it's like you gotta find a fine line because it's like, yeah, it's helping you, but it's harming you at the same time. So proceed with caution. What are we doing?
Yeah, I have one more from online and then maybe take one more.
Right, we'll do online.
Okay. I don't see it. I'm gonna do one. You want me to put this a little bit already. What do you want other men living with sickle cell to know? They may be listening today, but not ready to speak like that.
Speak up. Like seriously, I used to be super quiet, shy, and reserved, but again, they need us because again, the ladies they do a great job of getting their point and their story across. Fellas, speak up. I'm nervous, but it might seem like it. I am nervous, but again, I know. I wish I had this when I was a kid. You know me, because for the longest time, it felt like I was the only one on this planet with this disease because I'm the only one in my family that has it. So, you know what I'm saying? So it's difficult, but hope the next generation, the next person, you know what I'm saying? Whether you're younger or you can help somebody that's older, you know what I'm saying? Again, you're gonna be nervous, but again, we need you. Like seriously, like we need you.
I would also like look up support groups. You got Facebook, you got a lot of different platforms where you can find like-minded people that's gonna do the same thing that you want to do. And like recently, he just added me to one of his support groups. And every day is positive. Every day is positivity. Every day is, hey, come on, brother. Oh, that's how you feeling. That's how y'all handled it. And that's what can we do today? Like that. So I would definitely speak up. It's tough to be true.
I mean, take your time. But yeah, like even when we was having like the meeting or whatever, I can tell, like like this brother, he needed like some support. It's like just listen to him speaking and stuff. Because I'm like, look, I've been here before. You know what I'm saying? I still have those moments or instances where like, hey, like I feel like Tupac me against the world. So I was like, hey, bro, like after this, hit me up. Here's my number, blah blah blah. So yeah, I added him to the group because I'm like. Oh man, you from DC? Probably. Like I finally found somebody else. Like everybody else in the group is from LA or New York or across the pond in the UK. But yeah, so I'm just like, bro, yeah, I got you.
One question here, then we'll.
I have a question. I was gonna add on the pain management here. You were talking about, because he said, just always believe your patient when you're saying that. Because especially me, I think the situation is with doctors, I'm very tiny. When doctors look at me and based on what they see is what they describe. And I have a very high mentality. So, and then people who are constantly like on pain meds, like they're, they, build up tolerance and stuff like that. So this is about finding the right, and the middle ground and stuff, but I don't know how things are in Howard University. But majority of the time when I'm like, Baltimore, Washington, Medical Center in 2020, but they now have this being set up, like for somebody is in sickle cell, which are admitted, it's like it's kind of like, it's like the lower level of ICU, but they're monitoring you, like you're on like heart monitors and stuff like that, to make sure that you is not stuff. Sorry.
Yeah.
Okay. So I wanted to thank you all because I know it's a hard job to say some of the things that you all have said, because they're personal. My name is Dr. University Scholar, and I graduated from the Howard University course, and my brother was a person in the University of Florida. And Dr. John W. Downey, sir, I worked with you. Dr. John, I worked with you when I was 19 with young Dr. Roland B. We don't always know where our history is. So we will be a part of Yankee when I was 19. That's just like 10 years ago. Okay. So we have to thank the people who came before. So Dr. Brian knows every year I have to come to the evaluation function. And I carry my car for you from extra workshop to do it. And I have my hands with it. There's a run walk. So y'all need to keep online and check and be over there. That's great. I thank you all. I don't know, from the bottom of their heart, but I think on the top of them.
Get two more in.
I am a medical committee and I'm a medical resident. I come from a different background when it comes to pain management in sickle cell because I've done internal medicine residency in Nigeria, and I went into hematology, but because I have a sickle cell clinic, and the way we look at pain back home with patients who have sickle cell is different from what I have come to understand ever since coming here. We are very conservative when it comes to pain management in sickle cell. Not as much opioids have seen used in this environment. And I think one of the good things that we've been able to achieve back there is getting our patients to understand their pain figures in sickle cell. There are a couple of things that can make your chronic stable pain get worse. And if you are able to observe your body physiology and understand yourself and know the things that make your pain get worse, that can actually help limit how much pain medications that you get to need on a day-to-day basis. And that has really worked well for our sickle cell patients back home. Not a lot of them attend a special sickle cell clinic, which you run once every week. And most of our patients haven't come down with crisis because they've been able to understand their figures, and they've been able to, when it comes to the first few things we ask you are, what we've done in the last couple of weeks. We have a questionnaire, and then we discuss the figures, and it's really worked for our patients. And then we also have the support groups that we have. So this support group is composed of the physician managing this patient and the patient. So we get to talk once a month. We talk and the patient tell us about, we don't go talk like the patient and doctor saying, we talk like we are all ordinary people talking about our life experiences. People are able to express how they've been able to deal with common symptoms that they have. Just like they're having a discussion now, don't think about it. We are gathering once a month, telling me what we've gone through, the other person is saying what they've gone through, and it turns out saying, hey, I'm able to deal with this way. and if other people learn from it. So these are ways that we've been able to deal with these common complications that happen in sickle cell. And still be able to build a good doctor-patient relationship between all the physicians and the patients, because they get to talk about their problems in a non-clinic setting. They get to express themselves, and we get to actually be able to advise on how to deal with it. And they also hear from other patients how they need to deal with their situation. And this really has helped us to control how much medication patients get to be on, because understanding what works for you can actually go a long way in helping to reduce how much medication they get to take. So we can actually think about this as well and talk about it and see if we can contract groups to help you deal with this situation. Thank you very much.
Thank you.
We do have to wrap up, I'm so sorry, but I do want to take a moment just to recognize the panel. Because it does take a lot to get up here and share some football.
That's a great, thank you, put it back. So thank you so much. Thank you. You're running like short. I think they have a class.
Okay.
But thank you guys. See you for lunch. Let me just. Oh, yeah. I guess I'll do two first. Yes, I switched it back. But this is the new script. Oh.
Okay, we're just preparing to give a couple awards, and then we have a little memorial program at the end, and then after that, I'll make a quick announcement about lunch.
We'll just do the awards and then you want to hand it to her, or do you want to have it handed? Okay. You don't,
Yeah, but
don't get
let's
play
do
yet.
the awards
Let's
first.
do the awards.
Let me start.
But this, because the awards are on a different slide.
Okay. On, yeah.
Okay, those are, okay, stop sharing.
So follow all the way down.
This one. So. This one, right?
Yeah, starting.
Okay.
Or slide up.
This one on your side.
Go to the next slide.
Okay.
Yeah.
I'm about to share it right now. I'm about to share it.
Oh, okay.
Oh.
Good.
Okay, I'm gonna hand it over to Joanne.
So. Hi, I think Tanika's here, right? Okay, so I'm Joanne Adelberg. I'm a genetic counselor, family advocate in the Department of Pediatrics. We thank you so much for coming today, and thank you so much for this wonderful panel. I think that we learned so much today, and they were so brave for coming in and telling us their stories. We are moving on to awards right now. And first, just a little bit of personal information is the first time I met Tanika was in 2022 at the International Conference on Stigma. And she was the moderator on our panel, similar setup to this, but she was amazing. She was a great moderator. And at that time, I just saw how much passion and purpose she had for sickle cell. Being that she was a warrior herself, it was really amazing. And since 2022, I've met her at other venues. And more recently, I had the pleasure to hear her speak at the 2025 Maryland legislative session for bills regarding the education and advocacy for more service for sickle cell warriors. And Tanika was just like an Energizer bunny, like just absolutely amazing at that session. I know some of you here, were at that session and they know Tanika as well. So today we'd really like to recognize her. And she is the founder and executive director of the Sickle Cell Coalition of Maryland. So we wanted to present her. Go ahead.
Come up.
You could come up and we would love to present you with this award. Okay. Yeah, and if you can, sort of step into the camera so they could see you.
Award, let me read it out.
Yeah.
Okay, it says, making a difference to Tanika Hoffman for your dedicated years of outstanding service and commitment. Thank you for everything you have done. You truly make the difference. Excellence in sickle cell advocacy and outreach.
Thank you.
We'll take some pictures after.
Yeah, that's fine.
And then we have a certificate for her as well. If I can show it on the camera. Is it gonna work? I don't know.
There we go, just higher.
I didn't work too well.
Yeah, but so, did you want to say like one or two words and then we're gonna move on to like the next award?
Keep it brief. Yeah, just keep it brief. Just want to say thank you so much for the award to all the medical providers who fight for sickle cell warriors every day. I acknowledge you, my organization acknowledge you, and the patients acknowledge you, caregivers who fight every single day for us warriors. I know it's very difficult at times and it could be a lonely walk, but continue to walk alongside your warrior. And warriors, you all are the strongest people I know. Continue to fight. I know it can be very discouraging at times, accessing care, navigating a medical system that wasn't built for you, and oftentimes doesn't feel like anyone cares about you. But there are a strong group of people within our community and growing outside of our community that cares for us. So don't be afraid, like the gentleman said, speak up, share your story, volunteer, videotape yourself as you're going through the process, and continue to be an advocate. So thank you for the award. Thank you. Did you want a picture afterwards?
Yeah, let's go. That would be great.
Okay.
Yes. Okay. Do you want this? Okay.
Hello, everybody again. Can you hear me? No. Hello? It is something very special for me to acknowledge my colleague at Children's Hospital. Actually, we've been working for a very long time together. We did push study together. He was at University of Michigan at that time. Drew Campbell. But what I didn't know about Drew, he couldn't be here today, that he told me that, I have one mentor at Howard. And initially he won't tell me. I said, who? He said, I'll come here and tell you. Unfortunately, every time we have Roland B. Scott or John Downing lectureship, he hasn't been able to, come for a variety of reasons. Like today, he had 50 patients in his clinic scheduled, plus he has a parent-teacher conference that couldn't be postponed. But Drew told me that, the person who guided me to medicine and made me want to go into pediatrics was Dr. John Downing. So, and he still considers him one of the most important people who shaped his professional life. So I acknowledge Drew for all the wonderful work he does with the patients with sickle cell disease, and they have more than 500 active patients with sickle cell disease at Children's Hospital. And many of our patients, we take care of them together. They come here and they go to children as well. But of course, many of our patients who get admitted, they get admitted under his service. So him and Dr. Darbari do an outstanding job. We have recognized Dr. Darbari before for her work, but today we recognize Drew for the outstanding job he does as a very humanistic physician for children and young adults with sickle cell disease. Let's give him a good hand, but he cannot be here. But also, let's give a hand to Dr. John Downing for mentoring such wonderful people. John, thank you.
Okay, thank you, everyone. Really quickly, we're just gonna show you our past. We have an award we call Lifetime Achievement Award. We actually are not awarding one specifically this year for kind of a whole career of work. But we're just gonna quickly show you some of our past awardees. You may recognize, I'm gonna go kind of fast. Let's see if you recognize anyone. Oh, I didn't mean to go that fast. Okay, there we go. Oh, yeah, we know all that. Okay, so I'm gonna leave this on for a minute. I'll put it back up at the end. We're about to show a memorial slideshow. I'm hoping that Tammy and I can get the music working again. It's challenging for some reason. And then after that, we have lunch, box lunches right outside the auditorium. So you cannot unfortunately bring them back in here to eat. If you would like, you can bring them to the second floor in the cafeteria. So there's time to socialize. If you need to grab and go, you can do that as well. But we'd love for you to stay and talk to some of your colleagues that are here. All right, Tammy, for the survey, I will send it out on email afterwards if you're not into the whole scan code thing, or if you want to do it right now, you can. Otherwise, I'll send it in email. Okay. Yeah, but then he went down. It's down below. I know he was clicking on everything. I don't know what actually makes it work.
You're not gonna vector.
Yeah, I don't know how to get him. I do want to thank Tammy for helping us today. He was one of our former work study students in our unit here at Howard, and a Howard University student. So he's been very generous with his time. None of us are tech professionals. We're just trying our best. Yes.
I think he said he kept clicking on that crayon.
Yeah.
And then it automatically speakers. Yeah.
No, we don't.
Clicking it
And then he did like a. Go down where it says like test or something. I thought you like hit test and then it started working, like download. Where it went. So,
There.
yeah, like. Test. All right, well, I think we're just gonna have to listen, watch in silence. Unfortunately.
It can be still play out the laptop now.
Yeah, but they won't be able to hear it. All right, we're gonna start the memorial, so just please have a moment of silence. We're still sharing that other one.
Like, why isn't that showing up? Showing up the zones, but not showing up.
Well, but stop sharing that one. And then share that one.
I'm saying it's not coming up.
Oh,
It's like here.
let's try it again.
See?
There we go. Okay, these are the words to the song that should have been playing, so we'll make sure that we circulate a copy of the video in its entirety, because it is nice with the music in the background. But we thank you for your participation, everybody, and ask your remembrance for these warriors that we have lost along the way. And we hope that you'll join us again next time, but for now, grab your lunch and go visit with everybody here and have a great day.
I didn't work.
Yeah.
I give you blank? Or should I turn it all down?
Yeah.